This is the Postgraduate Pediatric Orthopedic video series. I'm Sattar Alshryda. I'm a pediatric orthopedic surgeon. In this video, I'll take you to how to perform telescopic nailing for femoral fracture, more specifically Fassier Duval nail. As we did with all our videos, we usually start with a clinical scenario. A 5-year-old child who is known to have Osteogenesis Imperfecta presented with right femoral fracture after minor injury. Previously, she had left femoral fracture, which was fixed with elastic nailing. Now she came to our center with right femoral fracture. She's fit and healthy otherwise, and she's ready to go for surgery. Our favorite telescopic nail is the Fassier Duval nail, and we strongly recommend to read the manual thoroughly before you launch on this operation. Fassier Duval nail consists of two parts, the female part and the male part, and they usually slide through each other easily. The lower end of the male part has three designs: the longer thread, the shorter thread, and the pin fixation. This is different from the tibia and the humerus one, where there's no long thread. In theater, I usually position these patients on the side with the affected leg uppermost. I put the leg on some cushion or pillows, and I'll try to pad all the bony prominence to prevent the pressure source. In single bone nailing, I don't normally use a catheter. However, if I anticipate longer surgery, I usually use a catheter. I isolate the limb on which I'm going to operate using U-drape. And as you can see, we handle the lower limb very gently, because it's not unusual to cause another fracture by rough handling. You saw earlier, we put some soft padding underneath the bottom knee, but also we need to do some soft padding between the two knees. What I usually use some fluffy dressing between on the top of the bottom knee, as you can see in this video. This is to prevent a pressure effect from the two legs on each other. I use a chlorhexidine for preparation of the surgical site. There's enough evidence to say it is superior to the betadine. And I usually prep the whole area from the top of my surgical field to include the foot. Then I use a disposable adhesive draping. This usually doesn't stick very well if the surgical field is still wet, so it might be worth it to give it 3 minutes for the preparation to dry off. At this stage, we change our gloves for a newer one, and we use IOPAN to further secure the edge of the draping to the skin. Secure this draping to the skin and prevent surgical field decontamination when the draping come off the skin. Then we connect our diathermies, and we do the second layer of preparation just before we start our surgery. I usually double check the size I plan to have for this child. By using one of the nails beside the bone, then I will take the x-ray, just to give me a rough idea which nail I'm going to use. There are several ways how to do Fassier Duval nail. One is the retrograde method, and this is what is explained in the manual or the brochure of the implant. However, I prefer in this particular child, when the canal is wide, when the bone is not bad, I prefer to use the antegrade method. This is because I will end with smaller incision for the whole operation, and I genuinely believe there's less risk of iatrogenic fracture with the antegrade method. So here I try to identify the greater trochanter, the back and the front, and usually my incision is around 2 cm above the tip of the greater trochanter, slightly to the back. Cut the skin and the deeper layer. Usually these children bleed more than average because of the collagen condition that they have. And in this area we cannot use tourniquet. Quite often I ask my anesthetist to give some tranexamic acid if I'm doing multiple osteotomies, just to reduce the blood loss and the need for blood transfusion. You don't have to have a smaller incision, but I always say the incision should be big enough for your finger to go in and feel for the full anatomy of the greater trochanter. You need to feel the tip of the greater trochanter, the back of the greater trochanter, and the front, because your guide wire, the placement of guide wire, rely on this feeling. Sometimes in children who are very young, the proximal part of the femur is not visible on the x-ray, so we cannot rely on the x-ray to determine the entry of our nail. and the feeling by the tip of the finger is most valuable. So this stage, take your time, make sure that you feel the anatomy very well. If the incision is small, make it bigger. I remember when I start doing these things, I usually make the incision big enough to see the whole greater trochanter. However, this is really not necessary. With a bit of experience, you can get the whole operation through the very small incision. After you identify your anatomy, try to use a guide wire, and please refer to the manual because there are different sizes of guide wire according to the size of the nail you use. This table taken from the manual and guide you through what size of the nail and what size of G wire or guide wire. What is not visible in this view is the X-ray. It is under the table and give me AP view of the femur. This is the AP view of the femur. As you can see, our guide wire in the middle of the canal. You can see also the flexible nailing and the plate that was done in the center. Usually a plate is not a good choice in osteogenesis imperfecta because of the stress riser. However, in certain situations, you don't have a choice. Also, we check the lateral views to make sure that we are in the middle of the greater trochanter and the middle of the canal. As I said earlier, sometimes in younger children you cannot see the greater trochanter because it's still not fully ossified. In this picture, we can see the tip of our wire exactly in the middle of the canal and the greater trochanter. So I'm happy with this position. Before I start my reaming, I double check that my entry point is perfect by feeling where my entry point is and where the greater trochanter is. I use tissue protector to protect the tissues from the reaming. Then I'll ream the proximal part using the reamer that's recommended by the manual. As you can see, I always refer you to the manual to make sure that you do every step in a systematic way. Sometimes I use power reaming and sometimes I use manual reaming. It depends on the quality of the bone and whether there's deformity or not. Here in the proximal part, as you can see, I used power reaming. Having finished reaming the proximal part, I'll pass my guide wire through the fracture site to the distal part. This I usually do it close if I can. But sometimes if this is impossible, I'll make a small opening at the fracture site and try to pass it under direct vision. It is ideal if we don't have to make another cut, but don't waste a lot of time on this stage. Give it 10-15 minutes trial of close passing of the guide wire, but if you cannot, just make a small opening. In this case, I was successful in passing the guide wire through the distal fragment. Partly because the fracture is well aligned and also the canal is wide. So I'll start reaming the distal part. Again, I use tissue protector and I go with the reamer that is specific for that nail size. Notice the position of the C-arm just to monitor the reaming, ensuring that I'm not breaching through one of the cortices. Next, we assemble the nail components to the nail driver. Here we ensure the flanges of the nail go into the slot of the driver and also the nail is locked to the driver by turning the red knob clockwise. Depending on the size of the nail, there are different color coded driver and we have to choose the right one for the right nail. Then after we assemble the nail driver, we introduce the nail component into the canal. We find the hole for the greater trochanter for the nail and we advance it gently and try to feed it through the fracture site into the distal fragment. Again, we need to be careful at this step because there's a potential we can penetrate through the cortices. Once we reach the end, as you can see here, I'm almost at the end in the middle of the epiphysis, but still there are a few threads through the epiphysis. I need to advance a bit more. So I'm going to advance a bit more and we check it both on the AP and the lateral. Again, still here we need to go more thread into the epiphysis to ensure that good grip at the epiphysis and it will not dislodge and migrate proximally. Here I feel better, there are more threads through the epiphysis and most of the shoulder of the nail through the epiphysis, both on the AP and the lateral, as you can see through these images. You might need to get a better pictures to be absolutely sure that you are the whole thread and the shoulders through the epiphysis. Have inserted the male component. Now we try to measure the female component, and I usually do this on the patient. So I put the female component beside the bone, and I take some x-rays to measure the length. And usually the length is the length of the bone after osteotomy and after correction, minus 7 to 10 millimeter, as shown in this picture, which was taken from the manual. When we mark where we need to cut the female component, we use high-speed diamond disc to cut the nail, as you can see in this video. After cutting the nail, usually the end cut is not very smooth. There are some debris inside the canal and some edges or ridges on the outside. The ridges on the outside can damage the bone, while the debris inside it prevent the sliding of the nail. So it's really important to smooth both the outside and the inside. I usually use the disc, the diamond disc itself, to smooth the outside, and I usually use the cone burr to clean the inside. After smoothing the edges and cleaning the nail, I'll ensure that the nail is sliding through each other. And now, with the male components already inserted, we slide the female component over the male component and slide it as far as it goes till the proximal thread reaching the greater trochanter. As you can see, usually go easily because we already checked it, it's sliding smoothly, and we'll push it until it reaches the greater trochanter. Then we try to engage the thread into the greater trochanter. Here, as we start engaging the thread in the greater trochanter, we take an x-ray to see what level we are, but also we use our finger to ensure that the whole thread has been buried within the greater trochanter. And when we are happy that the female component thread fully engaged in the greater trochanter, we'll cut the proximal end of the male component. For this, there's a special cutter provided in the set. When we cut the proximal end of the male component, we have to ensure the smoothness of the cut. And for this, there's a special probe we use for that. This comes in the set, and as you can see, this is the cut end. It slides easily through the probe, and we check the part that left in the body. Again, it slides smoothly, so we are happy with the cut. There's no problem. If there's any problem, try to cut it again to ensure it is smooth. Otherwise, the nail will not slide. Now the operation has finished in terms of stabilizing this child's femoral fracture. However, in these children with osteogenesis imperfecta, I usually put a single K wire or sometimes 2 K wires from the greater trochanter through the neck to the head. And the purpose of this wire to give strength to the femoral neck of this child, to prevent or at least to minimize the displacement of any future fracture in the neck. Because we know stabilizing the neck of fracture in the presence of Fassier Duval nail will be challenging. So by doing that, by stabilizing the neck and stabilize the femur fracture, we secure the neck and the femur. The only weak area left is the connection or the junction between the neck and the femur. Several techniques have been proposed to secure this region. However, none of them has been very convincing. I usually prefer to wait until the child older, and I change this Fassier Duval nail into a gap nail, which is specifically designed to protect this region. So to me, inserting a K-wire through the neck, it will give a lot of potential benefit, and it doesn't add to the time of the surgery more than 10 minutes. And here the AP and lateral views of the neck with the K-wire is inserted. When you're happy with the position of the K-wire, bend it on the trochanteric side and cut it short. and whatever prominent on the trochanteric side, try to punch it inside the bone. That's why it is a good practice to leave the tip or the pointed end of the K-wire around 5 mm from the growth plate. So when you punch it in, it doesn't reach the growth plate. But even if it does reach the growth plate, it is not dangerous. Usually these smooth pin does not interfere with the growth. And now we start washing our wound thoroughly using either saline or water for irrigation. Then we started closing the wound in layers, vicryl for the deeper layers and monocryl for the superficial layers. Then we use stir strips and a dressing. And when we remove our draping, we'll check the rotation profile of the lower limb to ensure they are symmetrical. If they are not symmetrical, we still have the opportunity to rotate it because the Fassier Duval nail allow rotating of the fragments. And when we finish the surgery, when we are happy with our rotation, we put hip spica. Is the hip spica essential? I don't think it is essential, but it will give some comfort for the child and also to ensure our rotation will not change. So my default position is to recommend hip spica. Usually it is single leg hip spica. And I usually keep it for a short period of time, for 2 weeks to 3 weeks, till the bone is a bit gummy and till the pain is well controlled. I don't leave it for 6 weeks or longer period of time, as this might affect the bone quality. Here I'm speeding the video a lot for the sake of time, but you can slow it down whenever you want to watch at slow motion. We've seen many hip spicas in the femoral fracture section, and this is not any different from that. And this will take us to the end of our videos. I hope you find it useful for both for the exam and for your clinical practice. On behalf of the Postgraduate Pediatric Orthopedic editors, we wish you all the best.